My name's Emily. I'm a third-year student registered nurse anesthetist. The purpose of this video is to support procedural learning by providing an easily accessible educational resource for ultrasound-guided radial arterial line placement. The intent is to deliver clear, practical instruction that promotes safe practice and improves the success rates of arterial cannulation using ultrasound guidance. During this presentation, we will review the benefits, indications, contraindications, equipment, preparation, ergonomics, ultrasound optimization, and a step-by-step technique for ultrasound-guided radial arterial line placement using the short axis and bevel-guided approach. Listed are some of the benefits, indications, and contraindications for ultrasound-guided arterial line placement. Ensure to maintain strict sterility at all times throughout the procedure. We're going to discuss the required supplies that you're going to need. An arm support, such as a towel for propping up the patient's wrist, a CHG impregnated dressing, a sterile ultrasound probe cover with sterile gel, an appropriate antiseptic for your patient, typically a CHG prep stick, tape to help with positioning and when you're securing the dressing, sterile gloves, and then you'll also need an arterial line kit, which contains a guide wire, a sterile drape, 2x2 gauze, a steel introducer needle, an angiocath, a longer catheter that threads over the guide wire and stays in place in the artery, 2 3 ml syringes, and red sharps disposal zones on either side of the tray. Maintain strict sterility throughout this procedure. Next, we're going to discuss patient preparation and positioning. Consistent provider and patient ergonomics are essential for procedural success. First, you will want to remove any ID bands or bracelets if needed and replace them afterwards. I would typically remove this patient's bracelet. The patient's hand should be supinated with slight wrist extension of about a 30 to 45 degree angle, which optimizes vessel accessibility. Avoid extensive wrist extension, which can collapse the artery or cause the catheter to dislodge once the wrist is neutralized. And then prep the patient with an appropriate antiseptic. As the provider, you'll want to stand upright with elbows close to your body. Position your tray within easy reach. Place the ultrasound screen directly in your forward line of sight. After the needle is inserted into the skin, you should always be looking at the ultrasound. You'll also want to anchor both of your hands during needle placement and probe handling for precision and to avoid any drift. For ultrasound optimization, you want to use a high-frequency linear probe. Adjust the depth to have the artery in the upper half to 2/3 of the screen. Increase the gain just enough to distinguish the lumen walls and needle. Overgain hides the needle tip. For probe handling, you want to avoid excessive downward pressure, which can collapse the artery. Use fine micro movements. This is an example of tilting, which is a heel-to-toe maneuver, and can help with finding the needle tip. Prior to needle insertion, assess the vasculature and vessel patency. To distinguish an artery from a vein, you can see that the artery, when compressed, is still pulsatile. It's non-compressible, it still stays open, and it's thick-walled. Veins are compressible and disappear when you apply pressure. Next, we will discuss needle insertion. Prior to inserting the needle, ensure the artery is centered horizontally and vertically on the ultrasound. Align the needle with the midline marker on the probe. Enter the skin at about a 30 to 45 degree angle and adjust based on that patient's vessel depth. Advance slowly using shallow angles. Track the needle tip by sliding the probe forward as the needle enters the skin. Maintain constant hand anchoring and keep your eyes on the ultrasound screen. Tilt the probe so the ultrasound beam is perpendicular to the bevel plane. If needle visualization is lost, stop advancing the needle. You want to slide the probe until the tip reappears, and only then continue. If needed, you may want to do a very slight lateral wiggle to assist with tip finding. Scan until the bevel shrinks and only the tip remains visible. Once the needle has entered the artery and is centered in the vessel, you can assess for blood return in the angiocath. Then advance the catheter incrementally. I always like to maintain a slight view of my needle tip so I don't lose it. Continue to advance the needle and then the probe until there is an adequate amount of needle in the vessel. You can then advance the catheter over the needle to the hub. While advancing the needle, avoid mistaking reverberation artifacts for the actual tip. The bevel or tip has the high-acuity of the needle. You may need to adjust your needle trajectory if the bevel appears off to one side of the vessel. At this point, you may also want to withdraw the needle slightly and redirect. I'm going to discuss some common errors people make when using the ultrasound while showing you a walking in of the needle. These errors include advancing the needle while not visualizing the tip, using excessive probe pressure, which can lead to artery collapse, making the lumen appear smaller, overuse of gel under the sterile cover, which can cause loss of fine tactile control, or underuse on the skin, which can decrease clarity of the ultrasound image. Next, we will discuss needle removal, guide wire advancement, and catheter placement. Before setting down the probe, ensure that the needle and catheter remain centered. Keep your probe in the sterile field in case you need to use it again. After removing the needle, you should have good pulsatile blood flow. If you don't, this could mean the catheter is not fully in the lumen. In this situation, you may have to do a second needle insertion above the previous insertion site. Or the catheter could be against or transversed through the back wall. In this situation, you may be able to slowly withdraw the catheter until blood flow is adequate. Do not attempt to insert the wire until there is adequate blood flow. With needle removal, you can use your third and fourth fingers above the point of insertion to limit blood flow before inserting the wire. When advancing the guide wire, ensure it advances smoothly. Never advance against resistance. This can cause a dissection or hematoma. It's not necessary to advance the wire all the way. When threading the longer catheter over the wire, you may want to hold the distal end of the wire to allow for more control. But do not allow the wire to become dislodged while doing this. You want to make sure it stays in the artery. Before advancing the catheter through the skin, ensure the end of the wire is visible and you always maintain control of the wire, as to never lose the free end of the wire. The wire should not be advanced, only the catheter. You may want to use the gentle rotating motion when inserting the catheter to allow for easy advancement through the skin. Continue to advance the catheter until it's at the hub. Next, withdraw the wire. You can use your finger to occlude excessive blood flow. Then, attach pressure tubing and make sure to secure the connections tightly. Then ensure you have a clear and appropriate waveform on the monitor. Next, remove the sterile drape and ensure the surrounding area is clean and dry. Then you will apply CHG impregnated dressing. Thank you for watching this video. Please complete a survey at the following link or using the QR code.